Good afternoon, everybody. Today we're going to talk about blood gas interpretation. This is aimed mainly at nursing staff, but anybody's welcome to watch. So what is a blood gas? A blood gas is usually an arterial sample, at least the useful ones are arterial samples, occasionally mixed venous samples when you're trying to assess cardiac output. To start off with, what does a blood gas test actually measure? We take arterial blood because this is the blood as it leaves the heart and the lungs, but before it goes to the tissues. So it shows the status of the blood after it has picked up oxygen and given up carbon dioxide in the lungs, but before the tissues have metabolized anything. A standard blood gas really only makes 3 measurements. Every other value on a blood gas is calculated by the computer that reports the results. The 3 measurements are the pH, which is the level of acidity or alkalinity of the blood. The second is the partial pressure of carbon dioxide, known as the PCO2. And the third is the partial pressure of oxygen, which is the PO2. Those are the only 3 things that are measured. So the bicarbonate, the base excess, the saturation on a standard blood gas, all of those are calculated values. And really, to interpret the blood gas, it's simpler if you only use these 3 values and ignore the other values, as they only amplify any errors in the measurement of the original values. So normal values, the pH in an average normal healthy person is 7.40. We usually give a range anywhere from 7.35 to 7.45 as the normal pH. Anything below 7.35 is acidosis, and anything above 7.45 is alkalosis. PCO2 in a normal person who's healthy and not sick, the average PCO2 would be about 40, and we give a range of 35 to 45. So if the CO2 is less than 35, that's hypocapnia, capnia referring to CO2, and levels over 45 is hypercapnia. And then for PO2, this is somewhat context dependent. Breathing room air, the PO2 should be something over 90, and this will vary with age and condition and pre-existing conditions and so forth. But if your PO2 is in the 90s, you're okay. You generally don't need to be put on supplemental oxygen as long as your PO2 is above 60. The saturation, which I only mention because of the ubiquitous use of pulse oximetry, there is a oxyhemoglobin dissociation curve that translates the PO2 into a saturation. So a PO2 of 60, assuming your pH is normal, translates to a saturation of 90%. A PO2 of 40 would give you a saturation of 75%. A PO2 of 80 would give you a saturation around 94% or so, and a PO2 of 90 would give you a saturation in the mid to upper 90s. You don't really have to memorize that, but that's just to give you an idea. A PO2 difference from 90 to 500 doesn't really change the saturation that much because that part of the curve is flattened out. So the saturation tells you the amount of oxygen bound to the hemoglobin generally in the blood, and correlates better with the oxygen content of the blood than does the PO2, because a partial PO2 of 500, while it sounds great, doesn't really deliver that much more oxygen to the body than a PO2 of 90 would. So excessive oxygen in most circumstances that are not carbon monoxide poisoning doesn't really make that much difference. So we generally try to keep the PO2s in treated patients in the hospital in the 60 to 90 range. And we would not use oxygen unless the PO2s were below that, unless there was a special circumstance. Pulse oximetry is subject to errors based on perfusion of the extremity where you attach the pulse ox, the ability to pick up an adequate pulse waveform, if there's poor circulation or poor circulation locally in the arm, and it also has racial differences where it can fail to detect oxygen desaturation in people with dark skin. So when we say that we'd like to have the saturation 90 plus, you really have to give some room for error. If you really want the true saturation to be over 90, maybe the pulse oximetry should be kept over 92 just to account for some of these errors. And you want to make sure you have a valid waveform on the monitor before trying to interpret a pulse oximetry. If you don't see a valid waveform that looks at least a little bit like an arterial wave, then the pulse oximetry value really cannot be trusted. A blood gas, if you get a true arterial sample, either from a line or a good stick of an artery without any venous blood, gives you the most accurate measurement of the oxygenation of that blood. Looks like somebody with money is taking off. So what controls pH? Well, if the CO2s go up, that creates acidosis that can cause the pH to fall. There also can be metabolic factors that can cause the pH to fall and create acidosis. We divide a metabolic acidosis into anion gap, where the anion gap is elevated, and non-anion gap acidosis. A non-anion gap acidosis is usually a result of a renal problem in most cases. Sometimes diarrhea could cause this if you have lots of bicarbonate lost in the stool. But for the most part, if you have a non-gap metabolic acidosis, this is caused from renal tubular acidosis and other such disorders. An anion gap acidosis, where the anion gap is elevated, can be caused by things like diabetic ketoacidosis, where ketones are responsible. It can be caused by lactic acidosis, and there's some various toxins that can also do it. You can look this up later if you're interested in the workup of metabolic acidosis. So when you look at a blood gas, the easiest way to interpret the acid-base status to me is to look at the PCO2, compare this to what the normal PCO2 is, and predict what pH should result from that PCO2. This requires a minimum of memorization, which we'll get into in a minute, but any change of that actual measured pH from what you predict based on the PCO2 results from metabolic changes, whether creating more acidosis or more alkalosis. If the metabolic change brings the pH closer to normal, you call this a compensatory or compensation. While on the other hand, if the metabolic effect on pH moves the pH farther away from normal, then that indicates a primary metabolic problem in addition to whatever the CO2 did. So the relationship to memorize is for every 10 that the PCO2 drops, the pH should rise by 0.1. Just memorize that. So if a pH of 7.40 and a PCO2 of 40, that 40 you would expect to lead to a pH of 7.40. And if it's not 7.40, the difference must be a result of something metabolic, whether it's alkalosis or acidosis. So that's the first step. For every 10 that the PCO2 goes up, in our example, we'll say the PCO2 went from 40 up to 50, then you would expect the pH to drop by 0.05. So a PCO2 of 50 should give you a pH of 7.35, while a PCO2 of 30 should give you a pH of 7.5. So write this down, memorize it. This is the most important relationship that you need to memorize when it comes to interpreting an arterial blood gas. So we can give some examples. If you have a PCO2 of 70, and we'll say the pH is 7.35, how would you interpret that? So the PCO2 of 70, what would we predict? That's a 30 difference from normal. So that means 3 times 10, so 3 times the 0.05 that the pH should be dropping gives you 0.15. So 7.4 minus 0.15 gives you a pH of 7.25. So if your pH is 7.25, then that is a pure respiratory acidosis or acute hypercapnic respiratory failure, if you're putting in a diagnosis for insurance purposes. What if the pH is 7.35? Remember I said that if the pH moves closer to normal, that's compensation. So if the pH is actually 7.35, when the CO2 would have predicted a pH of 7.25, that means you have a partially compensated or chronic hypercapnic respiratory failure. A PCO2 can change the pH in an instant, and the PCO2 itself can change in an instant. If you hold your breath for 30 seconds, your CO2 will go up enough that you can tell. The metabolic changes take hours to occur. And that's how you know it's a chronic process when the bicarbonate winds up being high or low. And again, bicarbonate is a calculated value. But if the metabolic component moves the pH to other than what the PCO2 created, that is a metabolic issue, and that means there was a chronic process one way or the other. So going the other direction, if you have a patient with a PCO2 of 20, so they're hyperventilated, we know that, because CO2 is a product of metabolism, and the higher the CO2, the lower the minute volume, and vice versa. The lower the CO2, the higher is the minute volume. So a PCO of 20 should give you a pH of what? That's 20 down, so that's 2 times 10. Remember we said that a PCO2 dropping by 10 would raise the pH by 0.1. That should raise the pH by 0.2 and give you a pH of 7.60. So if you have a PCO2 of 20 with a pH of 7.60, you have acute hyperventilation, and there's no metabolic component. On the other hand, if that pH is actually lower than 7.60, then maybe this is chronic hyperventilation and you have some metabolic compensation at work. So those are all examples where the metabolic component tried to move the pH closer to normal, meaning it was compensation. So what if we go the other way and we have a patient that has a PCO2 of 50 and yet their pH is 7.1? So what pH should a PCO2 of 50 give you? I'm listening for answers. Remember, for every 10 the PCO2 goes up, the pH should drop by 0.05. Therefore, a PCO2 of 50 should give you a pH of 7.35. But yet in this example, we said the pH was going to drop to 7.1. So what happened? So the acid-base disturbance is certainly a severe acidosis, and only a small part of that acidosis came from hypoventilation. The PCO2 is just not that high, but you have a profound acidosis. It's not a compensation, because the metabolic component, which is every part that's left over from what the CO2 does, caused the pH to drop significantly. So this is mostly a metabolic acidosis with a small component of respiratory acidosis. You can compare the relative disturbance of pH caused by CO2 to that caused by the metabolic component to determine which is the bigger process, whether it's mainly a metabolic acidosis or mainly a respiratory. In this example, of course, it's both, but you can tell clearly the metabolic component is bigger. Maybe the person was hypoxic and this led to severe lactic acidosis, or they could have just had poor tissue perfusion due to low blood pressure, low circulation, combined maybe with anemia to create a lactic acidosis that made the patient very acidotic from a metabolic standpoint, but also some hypoventilation. Another thing that commonly happens, if you have a patient with COPD, for example, that is accustomed to have a PCO2 in the 70s, and they're metabolically compensated, so you expect their blood gas to be something like a pH of 7.35 and a PCO2 of 70. So if you go through our interpretation trick, a PCO2 of 70 should give you a pH of 7.25, but if the pH is 7.35, that means there's metabolic compensation, and that's typical for a stable chronic hypercapnic respiratory failure COPD patient. So say the person comes into the hospital and they're sick and their PCO2 bumps up to 90, and we know, or at least we assume, that their normal pH at home was 7.35, but going up another 20 might drop them down to 7.25. So then let's say you put them on a ventilator or put them on BiPAP and you blow off some of that CO2, what's going to happen? Well, if you blow off the CO2 back to what they had at home, that PCO2 of 70, the pH will go back to the 7.35 that maybe they had at home. But if you blow their PCO2 all the way down to 40, even though the CO2 changes the pH right away, that metabolic component takes hours, if not days, to go away, or maybe a dose of Diamox in some cases. And that person's going to become very alkalotic. So if you lower a chronic CO2 retainer with compensated hypercapnic respiratory failure, you lower his CO2 down to 40, their bicarb might be 40 if we calculate that out, but the net effect is maybe their pH is going to be 7.6, and that's not good. Remember that pH is a big factor in potassium levels, so when your pH goes down, the potassiums go up, and when the pH goes up, the potassium goes the other direction, goes down. So you can cause hypokalemia by creating this metabolic alkalosis. Somebody that didn't really understand the clinical situation might look at that blood gas and decide this was all about a metabolic disturbance, but what really happened is the person is hyperventilated compared to their baseline. Even though that PCO2 may be 40 or even a little bit above 40, you created that alkalosis by causing their chronic compensation to be excessive. So your choice is either to back off the minute volume, or you can try to give a weak diuretic called Diamox that creates a little bit of metabolic acidosis to take some of that bicarb out and maybe reset their internal thermostat. So for people that have chronic CO2 retention, if their lung function is adequate, Diamox can help reset the CO2 that their body is willing to accept. So remember the relationship. For every 10 that the PCO2 goes up, the pH should drop 0.05, and for every 10 that the PCO2 goes down, the pH should rise by 0.1. So the steps again to interpret the acid-base status: look at the PCO2, use that relationship to predict what the pH should be, and then compare that to the pH that's actually measured. Decide if that metabolic component moved the pH closer to normal or farther from normal, and determine the relative contribution of the respiratory and the metabolic to creating that abnormal pH. Reminding you that if the pH moves closer to normal, it's a compensation. If it moves farther away from normal, it's a combined problem. Hopefully this helps. Feel free to leave your questions or comments in the comments below. Subscribe to the channel, like the video, pass on to your friends that have trouble with blood gases. To me, this is just the simplest way all around. You can't avoid having at least a little bit of memorization, but this gives you a systematic way to evaluate blood gases and acid-base status, and do it in a quantitative manner so you always know the relative contributions of the respiratory effects and the metabolic effects on pH. Until next time, see you later.